السلام عليكم. أشكركم على الدعوة الكريمة. أنا كنحس بلدي الثاني مصر. شكرا جزيلا على المستوى العلمي ديال المؤتمر. والآن نتكلم على الابيثيال mapping. So I will speak about epithelial mapping in refractive surgery. I have no financial interest in this presentation. So we know that epithelial mapping is a huge development of corneal imaging. And we know that now epithelium is not homogeneous. It's not the 50 microns in all the size of the cornea, but it is irregular. And the irregularity of the epithelium comes from the irregularity of the stroma. So the epithelium will fill the gaps to smoothen the surface of the cornea and to hide the surface aberration of the stroma. We'll see. So this is the theory of Dunn-Reinstein, and we will see here in a normal cornea the epithelium is regular. But when we have keratoconus, we have a protrusion of the stroma, the anterior surface of the stroma, and the epithelium will be thinner in the peak and will be thinner in the other sides to reduce the aberrations coming from the stroma. So the modification of the epithelium is the first aberrometric treatment of the keratoconus. The keratoconus is a stromal disease, and the epithelium tries to hide this high order aberration. What is interesting is here, the early keratoconus. The cases that we say it's normal on pentacam or other devices, we may have some early keratoconus, but hidden with the epithelium. And it can help us to exclude some false keratoconus. We can have some wrappage, and on other devices we can see a protrusion, hot spots. But when we have a thickening of the epithelium in these peaks, it is maybe not keratoconus, and we'll see other. So here you see So we have here the epithelium. It is thinner here and it is thicker in this place. It fills the gaps. So when we have scars, the epithelium comes to fill the gaps. So normal epithelium, when we do epithelial mapping, the normal epithelium is regular. It's not very, very regular because of the eyelids. It is a little bit asymmetric, but the difference doesn't exceed 5 microns. But it is sensitive to contact lens wearing, so the patients should remove contact lens, hard contact lens for 2 or 3 weeks, and soft contact lens for 3 days and maybe more. It is sensitive to dry eye. That's why when we have MGD, when we have problem with rosacea, with the problem of the eyelid, it is difficult to rely on the epithelial mapping. So we can rely on it if there is no dry eye, if the tear film is regular. And when we have the surface disease, when we have scars. Abnormal epithelium in keratoconus is a donut image. This image, this is in 3D. We have thinning in the center and thickening around. And the behavior we see here, we have a thinning in a side and thickening in the other side, and it represents the opposite shape of the keratoconus. It means we have the peak here. That's why we have thinning in this area. And here it is a decentrated keratoconus. It's not a central one, and we can localize the peak of the keratoconus by the epithelial mapping. Another case, the same. But when we have a hot spot in topography, and we have a thickening in the epithelium on the peak, it means means that there is not keratoconus. We cannot have a keratoconus with a thickening on the peak of the cone. But we have to compare with other information. We have some cases that it can be false, and we have to correlate all information. When we have some scars on the cornea, epithelial mapping is not reliable. We cannot use epithelial mapping to diagnose early keratoconus when we have any scar. I will show you some cases. Here we have a keratoconus, and we have a thickening of the epithelium. So we can say there is no keratoconus. But we have a scar. And when we have a scar, you have not to rely on the epithelial mapping to diagnose keratoconus. Another case, we have here this spot, and there is a scar when we have a haze after cross-linking, after any other surgery, after PRK, we cannot rely on epithelial mapping. So epithelial mapping we can rely when the cornea is perfectly clear. Another case, the same. So when we analyze epithelial mapping, not only this map, we have to analyze. We have to analyze a lot of information: the thinning, the thickening, the areas of the thinning and thickening, the average thickness, the shape of the epithelium. The shape of the epithelium is the most important one. There is no normal values of epithelium. You can have thick epithelium, thin epithelium, but the shape of the thinning, which is important in the diagnosis. And we always correct epithelial mapping to slit lamp examination. When I receive some topographies from other doctors, sometimes I take the patient to the slit lamp to give a good result. High definition OCT scans, curvature maps, elevation maps. So we have here all this to have the decision if it is reliable or not, and to give a diagnosis. We can use it also in other intraocular rings. We can see the thickening over the peaks, over the rings, the thinning over the rings. And so we can compare between posterior elevation and which is better, epithelial mapping or posterior elevation in the diagnosis of early keratoconus. We will see some cases. Here we have small asymmetry, but normal posterior elevation. Normal, okay, it's borderline. But when we do epithelial mapping, we have a donut. So it's a keratoconus. And when we see the fellow eye, the fellow eye, it is a keratoconus in the fellow eye. So we have some other cases, it's the same thing. When we have any asymmetry in pentacam, we have to look to the epithelial mapping to confirm the donut. I want just to show you one draw. So it's not homogeneous. Irregular stroma will give irregular epithelium. And when we have irregular epithelium, it means there is an irregular stroma. So here, what I want you to show you is this. So when we have a very early keratoconus, and we use the posterior elevation map. So we trust in posterior elevation map when it is normal, there is no keratoconus. There are some cases where in very early keratoconus, the values of posterior elevation are normal, and you have abnormalities on epithelial mapping. That's why I think that epithelial mapping is better than posterior elevation in diagnosing early keratoconus, and thank you very much.
Many thanks, Dr. Rifay.